All right. So as we discussed that we are going to have a series of lectures on cardiovascular drugs, and these lectures are going to be detailed lectures. In case you do not want detailed lectures, we can have short lectures with high material as well, but we'll start with detailed, excuse me, we'll start with detailed lectures, and we will also discuss a little bit of pathophysiology so that you understand what we are discussing and how the drugs will be applied in case of heart failures, all right? And we will have 50 minutes lecture. After that, we will stop, which means that we will have this lecture in 2 sessions or maybe more than 2 sessions, right? We will go slow so that you absorb things and you can retain things, all right? So let's start, and let me start with this red alert, all right? Now, heart failure, according to American Heart Association, heart failure affects 5.7 million Americans of all ages and 60 million worldwide. So that's bad news. Maybe it's good news for the hospitals that do business, and maybe it's good news for the cardiologists, but that's not a good thing, all right? Heart failure is responsible for more hospital admissions than all forms of cancers combined, right? And in 2010, the estimated cost of heart failure in United States was $39.2 billion. So what I'm trying to tell you is that heart failure is a real burden on health resources and the healthcare givers, okay? Now, before I start with the drugs, as they say, I'm going to set the stage and then we will dive into the drugs. And just to find out your current knowledge, I'm going to ask you some questions. And throughout the lectures, I'm going to ask you questions which are going to be USMLE type questions that will give you some practice for your examinations for those who are going to appear in their examinations. So let's see whether you can answer this question or not. The 2021 Dietary Guidance to Improve Cardiovascular Health from American Heart Association recommends that at least how many minutes of moderate physical activity per week. Now, I've shown you the stem of the question only. I'm going to give you the choices as well. The thing is that you must read the stem very, very carefully in your examinations. All right, after reading the stem, there are certain points, sometimes some keywords that the students miss, and then they choose the wrong answer. So let's see whether you can answer this or not. You can write on the chat, you can speak, and all right. Noshin said 150 minutes, which is perfect. That is the right answer. 150 minutes is the right answer. Doctors, usually the cardiologists, they would recommend, I mean, not young people like all of you can do a lot more exercise, but people, old people like me, they have to do some exercise. That is about 30 minutes per day of walk. Yes, Dr. Aziz also said 150 minutes. So that is good. What are the common signs and symptoms of heart failure? Well, sometimes more than one answer could be correct. So it's not because this is not an examination. This is just reinforcement of your knowledge. So maybe more than one answer is correct. All right, I'll give you the answer. All of these are correct. You know, these are the signs and symptoms. Yes, very good. All of the above, okay? So all of these are correct. I've got 2 more replies. Well, I already gave you the answer. Right, so let's keep going. And so heart failure, right? Anybody knows the definition of heart failure? When we say the heart is failing, what do we mean by that? Let me see if you want to speak, you can speak. I have not muted everyone. Okay, mute all. Yes. Okay. Right. Okay, I'll give you the definition. There are many definitions of heart failure depending upon our perspective. All right. So, functional inability of the ventricle to meet the metabolic demand of the body. Right. So, heart is the organ that pumps blood to all the tissues in the body, to all the organs of the body. And the purpose of the heart to send blood is to provide the tissues with enough oxygen, nutrients, amino acids, vitamins, minerals, so that the cells in those tissue could perform their functions. All right. So heart failure is a challenge to be reckoned with. Okay, it's not something simple. And in this lecture, I'm going to give you some medicines that, the treatment paradigm for heart failure has sort of changed a little bit. Okay, there has not been a dramatic change, but there have been some new drugs, and the first line drugs have also changed that I'll show you as we go ahead. All right. But before I go ahead, last year also we had this lecture. We had a series of lectures in cardiovascular that included anatomy, physiology, embryology, and pharmacology as well. But this time we are going to do only pharmacology. All right. And just to give you a few statistics on the heart, the heart contracts approximately more than 100,000 times per day, 39 million times in 1 year, and 3 billion times in 75 years. The heart pumps 14,000 liters of blood per day and 10 million liters in a year through 60,000 miles of blood vessels. Now, that is what I call unequaled performance and robustness of an instrument. That's the difference between the nature's products and the man-made products. Don't come anywhere near to what the nature makes automatically, right? And it sees what is invisible to the eye. That is a little bit of poetry over there. And a question for you. Which of the following would not be an expected sign of right-sided congestive heart failure? Let us see. Now, this is a negative question. We don't use negative questions in the examination. But again, as I said, this is a lecture, so it is a negative question. Following would not be an expected, which means 3 are correct and 1 is wrong. And Noshin said C, which is perfect. Some of you might have been confused with pleural effusion because we would expect pleural effusion with left-sided heart failure, because if there is a left-sided heart failure, the pressure will be transmitted back to the lungs and we can get pleural effusion. But there is sufficient evidence that pleural effusion does occur with right-sided heart failure as well. So the correct answer obviously is pulmonary edema. Which of the following is not a result of activation of something is hidden from my view. Right. I hope you can see it. Okay. Right. So the thing is that the heart muscle cells, they are non-dividing cells. Okay, they do not divide. And well, which of the following is not a result of activation of renin, angiotensin, aldosterone? Both angiotensin and aldosterone do cause cardiac remodeling, all right? So I'm afraid A is not the correct answer. Both angiotensin, aldosterone in the long term cause fibrosis. Fibrosis and remodeling are more or less the same thing, although remodeling is a little more than fibrosis. But as I said, the heart muscle, they are permanent, non-dividing cells. And you know, hyperplasia means increase in the number of cells. So the correct answer, yes, the correct answer is B, all right? So definition of heart failure, we will look at another more clinical definition. Not being able to fulfill the metabolic needs is a basic science definition. And I will give you another definition after this one. Heart failure is a complex clinical syndrome that results from any structural or functional impairment of ventricular filling of ejection of blood. Now, impairment either of ventricular filling, which means it is a diastolic problem, the ventricles fill during diastole, or it is an ejection of blood, which means systolic problem. All right. Now, let me say the same thing in other words, which is it is a syndrome of low cardiac output, which down the stream has got many other effects. All right. So it is a syndrome of low cardiac output, which has the following effects. And let me show you what the effects are. The cardinal manifestations, these are the effects that it has, which are dyspnea. Obviously, this means there is some problem with the lungs, fatigue, and fluid retention. And dyspnea and fatigue will lead to decreased exercise tolerance. Well, the patient might not come to you with dyspnea. He might complain of fatigue and tiredness and decreased ability to perform daily activities, right? And the second is fluid retention, which is further going to lead to pulmonary congestion, splanchnic congestion, and peripheral edema, all right? So in your clinics, when you see heart failure patients with different presentations, majority complain primarily of edema, dyspnea, or fatigue. Some have exercise intolerance, but little fluid retention, right? But you know, the thing is that most of the patients they don't come early in the early phase of the disease. And most commonly, yes, exertional dyspnea is correct. Most commonly, patients come with swelling of the ankles or the feet. And then on further examination, echocardiography or whatever, we can see that the cardiac output is low, all right? So here is an update. This is from the Heart Failure Society of America, Heart Failure Association of European Society of Cardiology, Japanese Heart Failure Society, and a universal definition, which is more applicable, more practical in your clinics. Heart failure is a clinical syndrome with symptoms or signs caused by structural or functional abnormality. And what we will find, elevated natriuretic peptide and pulmonary or systemic congestion. Both of these we can find with the help of the lab or our clinical examination, right? So same thing, symptoms and signs of heart failure caused by structural or functional cardiac abnormality. Elevated natriuretic peptide, you know that we have two types of them. We have anti-proBNP and we have got BNP. I'll give you the normal ranges as we go ahead. And objective evidence of cardiogenic or pulmonary systemic congestion, which is, of course, we can diagnose clinically, right? Let's go to the common causes of heart failure. There could be pericardial, like pericardial effusion, myocardial, most common, cardiomyopathy, endocardial, endocarditis could lead to heart failure, and valvular, you know that vascular, obviously, ischemic heart disease could lead to heart failure in the long run. So coronary artery disease is the most common cause. Slowly and gradually, coronary artery disease means that the supply of oxygen to the heart is low, especially under conditions where the heart needs more supply of oxygen and nutrients, like in exercise, or even you can say increased physical activity, not necessarily exercise. Myocardial infarction, obviously, when a part of heart muscle is damaged, the heart will not be able to pump a sufficient quantity of blood. Hypertension, it is 60 to 89% of heart failure with preserved ejection fraction. I'll come to this in a minute. Valvular heart disease, that's not difficult to understand. Cardiomyopathy, infections, alcohol abuse, drugs, genetic, and an example is dilated cardiomyopathy. Congenital heart disease, and arrhythmias, right? Now, physiological adaptations of CVS to increased workload. This is a little bit of physiology that is relevant to heart failure, right? What does the heart do when the needs for more pumping or more cardiac output arise, right? So one is Frank-Starling mechanism, and I'm sure you all remember this from your physiology. I'll just show you with the help of this graph. On this x-axis, I'm going to show you left ventricle end diastolic pressure, which means the venous return, or you can say that the amount of blood at the end of diastole in the heart, and this shows the stroke volume. Now, the stronger the contraction of the heart, the more will be the stroke volume. So let us see what the graph tells you. What it is showing you is that as the end diastolic pressure, sorry, I said volume, it shows pressure, but pressure will be more when the end diastolic volume is more. So both are the same things. End diastolic volume increases and diastolic pressure increases, okay? The wall tension increases, right? So as the end diastolic pressure or end diastolic volume increases, the force of contraction increases. And when the force of contraction of the heart increases, the stroke volume, the cardiac output is going to increase. But as in every organ, the heart also has a limit. Under resting situations, normally our end diastolic pressure is 8 millimeter Hg and our stroke volume is 70 ml, right? And cardiac output is, of course, stroke volume into heart rate. You can calculate that. But the limit of this Frank-Starling mechanism is about 15 millimeter Hg, and the stroke volume at this pressure or certain end diastolic volume, the stroke volume levels off. Okay, it's somewhere around 100 ml in one heartbeat. Stroke volume is the amount of blood that is ejected in one heartbeat. So somewhere between 90 and 100 is the maximum stroke volume. But obviously, we are talking of averages, right? If you talk of athletes, obviously, they have got very strong hearts and their stroke volume is a lot more than normal people, and so is their pulse rate, which is a lot lower than the normal people, all right? Right, ventricular hypertrophy. Now, ventricular hypertrophy, when I say a ventricular hypertrophy, I mean physiological hypertrophy. Physiological hypertrophy of the heart is seen in people who do physical exercises, like these Olympic athletes and players, football players, tennis players, bodybuilders who are doing exercises 7 to 8 to 10 hours a day, all right? So that is physiological hypertrophy. The hypertrophy that you get as a result of hypertension or that you get as a result of valvular heart disease is pathological hypertrophy. There are histological differences between physiological hypertrophy and pathological hypertrophy, all right? I'm giving you a little bit of pathophysiology as well. In physiological hypertrophy, there is going to be increase in the size of heart muscle fibers. The individual cells, the number of sarcomeres, actin, myosin filaments is going to increase. But in pathological hypertrophy, it is the extracellular matrix that is going to increase. So the what you call the mass to cavity ratio is going to increase, but the increase in mass in pathological hypertrophy is more due to increase in extracellular matrix, all right? I hope you all got this point. Right, increased sympathetic adrenergic activity, that is not difficult to understand. These catecholamines, norepinephrine, epinephrine, they increase the force of contractility through beta-1 receptors in the heart. Heart has got 80% beta-1 receptors. They are there in the SA node and AV node as well. And decreased activity of renin-angiotensin system. Obviously, you know, renin-angiotensin system is basically controlling the volume of fluid in the extracellular fluid, okay? Or you can say that indirectly in the long term, it controls the blood pressure. Right. Another question for you: which of the following is true regarding catecholamine toxicity to the heart? Well, this shouldn't be difficult for you. All right, so catecholamines, which are epinephrine and norepinephrine, they will increase the heart rate and contractility. So definitely they're not going to decrease myocardial oxygen demand. All right, they're going to increase oxygen demand. They're going to increase the heart rate. They have a greater tendency towards arrhythmias in certain people. You know, when you give epinephrine injection under certain situations, like what you call that that sort of that shock, you know, which is due to, just slipped my mind. Anyway, even when you give epinephrine in certain types of shocks, there is always anaphylactic shock. Sorry, so there is always a risk of developing arrhythmias. So the answer is it's a little more molecular, deeper answer. It causes intracellular calcium overload, because when the epinephrine and norepinephrine bind to beta-1 receptors, which are G protein coupled receptors, they increase the amount of cyclic AMP, and that eventually causes influx of calcium and release of calcium from the sarcoplasmic reticulum. All right. Okay, next question. Which of the following is true regarding natriuretic peptides? Important question. Now remember, natriuretic peptides are good for the heart, all right? And we have now drugs that maintain a certain level of natriuretic peptides and that we use in heart failure. So anything which is not good for the heart is wrong over here. Okay, now Noshin has said B promotes sodium retention. Sodium retention is not good for the heart, because sodium retention is going to cause fluid retention, and fluid retention is going to increase afterload and preload. One answer, B, is not correct. Contribute to balanced vasoconstriction. Vasoconstriction is going to increase afterload, so that is not good for the heart. Increase vasopressin ADH release, that is going to increase intravascular volume, fluid expansion. It is not good for the heart. So the correct answer is antagonizes the sympathetic nervous system, which is the right answer in this case. All right. Okay, now let's go back to heart failure. When a person, what I'm showing you over here is, you see, this is the normal size of the heart. This is the heart and the aorta and the pulmonary trunk. And when there is heart failure, there is dilation of the heart, okay? So this shows you the enlarged heart over here. And as a result of poor pumping ability of the heart, there is going to be back pressure, transmittance of pressure into the lungs, and especially in left ventricular failure, we can get this pleural effusion, which has been shown in this X-ray over here. I hope you are able to see this one, all right? And compensatory mechanism. Now, this is important to understand, because what we treat in heart failure are the what you call the detrimental compensatory mechanism in heart failure, right? So Frank-Starling mechanism, that is a good thing. I mean, we cannot do anything about Frank-Starling mechanism. Frank-Starling mechanism tries to maintain the cardiac output up to a certain limit. But when the limit crosses the end diastolic pressure of 15 millimeter Hg, then it is not going to work, all right? And I showed you that thing in this graph in the previous slide. The sympathetic nervous system is a culprit. You know, it's a good thing. We need sympathetic nervous system under normal circumstances in emergencies, but when the heart is failing, the poor heart is sick. If a person is sick and you tell him to work more and to work faster, And to go a long way, that's not good for him, you know. So sympathetic nervous system stimulation as a result of heart failure, what happens is when the heart fails, the organs and the tissues, they are not getting enough oxygen and nutrients for their metabolic needs. So they send messages to the brain that we are not getting enough. So the brain, through sympathetic nervous system, autonomic nervous system, will send message to the heart to work more. But working more for an ill heart, a failing, a weak heart is not a good thing. So we have to control this thing. Right, the renin, angiotensin, aldosterone system, when the cardiac output is low, the blood flow to the kidneys will be low, and the granular cells in the afferent arterioles are going to secrete renin. That is going to convert angiotensinogen into angiotensin 1, then to angiotensin 2, and then release of aldosterone, sodium and water retention, and increased workload for a failing heart. Not a good thing. All right. Natriuretic peptides are very good. You know, they are produced and secreted by heart muscles. We have got atrial natriuretic peptide and brain natriuretic peptide, because in pigs it was first discovered in the brain. All right. And we routinely measured these in the heart failure. And the higher the levels, the worse the heart failure. Okay. Endothelins are not good for the heart because they produce vasoconstriction. Inflammatory mediators, they are markers for heart failures, right? Because heart failure is a chronic disease, right? So these markers of chronic disease, C-reactive protein, which stands, by the way, many students do not know. When I ask them, what is C-reactive protein? What does C stand for? Can anybody tell me what does C stand for in C-reactive protein? Please write on the chat. Well, it stands for complementary active protein, all right? So that will be increased, and myocardial hypertrophy and remodeling. Now, this remodeling is a bad thing. You know, once fibrosis occurs in any tissue, it is irreversible, right? There is loss of tissue, that's gone. Fibrosis is never reversible. And obviously that is going to lead to dilation of the heart. Now, dilation of the heart, what is the problem with the dilation of the heart? Okay, now that is what I'm going to show you in this figure. There is a small little video that I don't know whether I'll show it to you or not. So this is a normal heart, and this is a dilated heart. Obviously, it has been taken out because the person was undergoing a heart transplant. Now, what happens when the heart is dilated? And that is what I'm going to show you over here. These are just the fibers of the heart, the muscle fibers, their arrangement in a certain way. There is a question from Dr. Fayyaz that in these compensatory mechanisms, which one cause hypertrophy of the heart? The hypertrophy of the heart is caused by increased afterload. All right. And I'll explain to you what, you know, this renin, angiotensin, aldosterone system, that is going to increase the afterload. So that is going to cause hypertrophy. Usually, you know, as I said, that hypertension is a very important cause of heart failure in the long run. So hypertension can cause hypertrophy, that is pathological hypertrophy. All right. So there is a difference between hypertrophy and there is a difference between dilation of the heart, right? To some extent, sympathetic nervous system can also lead to hypertrophy of the heart. You know, any increased demand for work. So let me repeat. Any increased demand for work in any tissue will lead to hypertrophy. That is the basic pathophysiological mechanism. I hope you got my point? Right. So what I was showing you in this figure was because of the dilation of the heart, something happens in the sarcomeres to the actin and myosin filaments. Now, this is just a very short video. Let us see what it is. This just shows you the contraction of the heart. It shows, some people say that, you know, because of the arrangement of fibers, when the heart contracts, it twists a little bit, but I'm not sure how correct that is. But this This twisting movement is like wrenching, a cloth. If you want to drain water out of cloth, you just twist it, and the water will go out of that cloth. But anyway, what I'm trying to show you over here is this is a sarcomere, right? I've shown you two sarcomeres over here. Now in this sarcomere, if you see, these are the actin filaments and the myosin filaments. There is a very good overlap between the actin and myosin filament. And the better the overlap, the stronger is the capacity of the heart to contract, because the actin and myosin, the myosin heads and the actin filaments will engage, and that will lead to contraction of the heart. But look what happens due to dilation of the heart. As a result of dilation of the heart, these sarcomeres, they are also stretched. And when they stretch, the actin and myosin filaments do not overlap. When they do not overlap, or they do not overlap optimally, the heart becomes weak. In this situation, there is no overlap. So that is the end. The heart cannot work, and the only treatment over here is cardiac transplant or left ventricular assistive devices. Sensitivity and specificity of BNP, I'm sorry, I do not exactly know, but I can check that for you and I will let you know. But obviously there is no test which has got 100% sensitivity and specificity, and diagnosis is always a combination of physical examination, your clinical examination, and not one test, but many tests. All right. So if you have to diagnose, what I can tell you over here is the higher the levels of NT-proBNP and BNP, the worse is the heart failure. All right. But you will do that in combination with your echocardiography. Maybe you do an X-ray, maybe there are other tests, you do a thallium scan or whatever, So overall, the severity of heart failure could be measured with a combination of different tests. But your basic question, the specificity and sensitivity of NT-proBNP, I don't know, but I can check that for you. Right, so definition of heart failure, ejection fraction is considered important in classification. So this is another thing, all right? In heart failure, ejection fraction is one of the measures of the severity of heart failure, besides NT-proBNP. Most clinical trials selected patients based on heart failure, and as I'm going to show you, we classify, there are many different ways of classifying heart failure. One of them is ejection fraction that I'm going to show you over here. We have got heart failure with reduced ejection fraction, which is less than 40%, and this is known as systolic heart failure. And we have got many therapies for that. And this is known as heart failure with reduced ejection fraction. We call it HFrEF, as I'm sure you know. Then we have got heart failure with preserved ejection fraction, HFP, we call it HFpEF, when ejection fraction is more than 50%. Well, ejection fraction more than 50% does not mean that the cardiac output is good, all right? So that is physiology. We'll discuss that some other time if you want. So this is diastolic heart failure. Here it is a problem with the filling of the heart. Although the ejection fraction is all right, but the heart is not being filled properly. It is not being filled with enough blood to be ejected, all right? That's the problem over here. So unfortunately, we do not have efficacious therapies for diastolic heart failure. Now, again, I'm going to show you the classification, as I said, which is based on this ejection fraction. All right, so previously we called it mid-ranged ejection fraction, as I'm going to show you over here. Now, HFrEF, I just said it's less than 40%. Okay, we call it heart failure with reduced ejection fraction. HFpEF is more than 50%, but the cardiac output is low, right? The heart is not filling with enough blood. Now, this was previously known as mid-range heart failure, but now, according to these latest guidelines, that were finished. There is a question from Dr. Aziz, clinical differentiation of systolic and diastolic heart failure. I'll just come to that in a minute. First, I'll explain to you this thing that there has been a change in nomenclature about 4 or 5 months back in 2021, and now this is known as mildly reduced heart failure, which is 40 to 49%. All right. And then obviously heart failure with preserved ejection fraction is greater than 50%. Now, let me go back to the question that was asked, clinical differentiation of systolic and diastolic heart failure. Well, the first thing is echocardiography. Echocardiography can tell us the end diastolic volume. In heart failure with preserved ejection fraction, it is the dilation of the heart that is affected. The heart is unable to dilate. The heart is unable to take enough blood. All right. Secondly, it is more common in women for some reason that I do not know, unfortunately. So, and it is very common. Some books mention that heart failure with preserved ejection fraction is as common as heart failure with reduced ejection fraction. But the main thing is because the heart is not able to dilate enough, it is not filled with blood. It is a filling problem, not a pumping problem. All right. The pumping of the heart is all right, but the filling of the heart, the end diastolic volume is measured in echocardiography. All right. So I hope that answers to your question to some extent. But let's get back to the normal levels of BNP and NT-proBNP. This is 35 picogram and 125 picogram. And this could go in thousands in patients, all right? So the higher it is, the worse the heart failure. At least one additional criteria, as I said previously, heart failure, functional or structural defect, which will increase the natriuretic peptide. And it will also cause pulmonary congestion, right? Structural heart disease, what do we mean by structural heart disease? Left ventricular hypertrophy or left atrial enlargement, which of course is due to malfunction of the left ventricle, all right? So let's go to the signs and symptoms. We have a few minutes left. Sir, can you please explain how in diastolic, I'm reading a question over there, how in diastolic heart failure ejection fraction is not changed? Now, let us first discuss, that was in my pathophysiology lecture. I wish I had that slide over here. Can you tell me what is ejection fraction? It is the percentage. It is the fraction or the percentage of end diastolic volume that is ejected from the heart. The fraction, it is a fraction, ejection fraction. It is the fraction of the blood that is ejected from the heart in systole. So fraction of what? Fraction of end diastolic volume. Now, what I said that this diastolic heart failure is a filling problem, right? Let us suppose, now, normal ejection fraction is 55% to 70%, people say, all right? Let us suppose that the heart fills 100 ml. The normal filling of the heart is 150 ml. I'm just giving you arbitrary figures just to make you understand, right? Let us suppose that the heart fills 100 ml, okay? And the normal filling is 200 ml. Now in 100 ml, normal ejection fraction is 55 ml or 65 ml, right? Because the normal ejection fraction is a percentage of the end diastolic volume. So here in case of diastolic heart failure, although the ejection fraction is normal, but you are ejecting just 55 ml of blood, whereas normally the end diastolic volume is 200 ml. Let us suppose 55% ejection fraction means 110 ml of blood, okay? So although the ejection fraction in compromised filling of the heart is normal, but it is too little because the filling is too little. Did you get my point? I didn't get any answer. All right, that's good. If you want, I can bring a slide tomorrow because we are not going to finish this lecture today. In any case, we are still setting the stage, by the way. I have not yet gone to the drugs. Right, let's go to the signs and symptoms. That easy, fatigue and dyspnea and exercise intolerance. These are the classical signs. Palpitations could be there. Paroxysmal nocturnal dyspnea is there. Angina, dry cough at night. And treatment of signs and symptoms is one of the goals of treatment of heart failure, right? Sometimes we give symptomatic treatment as well. I'll quickly go through the this classification of heart failure. There are two types. One is New York Heart Association, which is a functional classification, and one is American Heart Association and American College of Cardiology, which is all based on structure and signs and symptoms, right? But there is a new classification, okay? That is again latest update about a few months back. So see, we are looking at two things in New York Heart Association classification. What happens to the patient at rest and how much ordinary physical activity it can do, right? So let's quickly go through this. The patient is comfortable at rest in class 1, class 2, and class 3. So that's easy to remember. So what is the difference between class 1, class 2, and class 3? I'll tell you in a minute. Class 4, you know, symptoms are present at rest. Cardiac insufficiency is present, and there is grossly limited physical activity. So class 4 is the end stage, okay? The most severe form. Now, let us go back to class 1, class 2, and class 3. In all of these three, at rest, the patient is comfortable. There are no symptoms in class 1. In class 2, there are very mild symptoms. And in class 3, there are severe symptoms. Now, what do I mean by mild symptoms and what do I mean by severe symptoms? Slight limitation of physical activity. Now, there is a 6-minute walk test, if you are aware with that. We can measure slight limitation and let me see what mark limitation by this walking, either walking 2 to 100 yards, but more standardized is a 6-minute walk test. How much a person can walk in 6 minutes? Maybe a young person like you can walk in 6 minutes. I don't know, maybe 300 yards or whatever, you know, young people can even run. But a patient with heart failure may not even be able to walk if there is marked limitation. Maybe after 20, 25 yards, he's going to get breathless. Okay, so slight limitation and marked limitations. There could be other tests as well, like climbing the stairs, okay? But here you have to be careful that the patient doesn't have any coronary artery disease. And in class 4, as I said, this is the last stage. He is unable to carry out any physical activity. He is bedridden, okay? So that explains the New York Heart Association functional classification. And this is the newer classification. This was published, I think, somewhere in June or May in 2021, which means 6 or 7 months ago. This is a pre-heart failure. This is a new stage that they have added over there. Okay, more or less it is, you know, at risk. Here also it is at risk. There is no problem. The patient is comfortable as at rest, no symptoms. Same in American College of Cardiology stages of heart failure, right? Stage 1 is just the risk of developing heart failure. What is the risk of developing heart failure? Well, it could be coronary artery disease, it could be hypertension, it could be diabetes, right? But here they have added this one, they call it pre-heart failure, and there is some explanation. I'll give you the handout. There is some self-reading that you have to do over here, right? And this is based on evolution of disease progression, American College of Cardiology, American Heart Association. I'll not go through this. I'll see the first stage is just risk, and the last stage is the end stage disease. It means heart transplant, okay? Again, this slide, I'm not going into details. It is giving you the signs and symptoms. This is more of a pathophysiology slide. In the handout, you will have this slide and you can read it on your own, all right? So far, what I have done is I've gone very slow. It's already, I see, about 45 minutes. So we discussed the definition and signs and symptoms of heart failure. We discussed the causes of heart failure. We discussed the physiological adaptations, compensatory mechanisms. We discussed why in heart failure, eventually you have to go to the transplant of the heart. Then we went to the ejection fraction and we classified heart failure on the basis of ejection fractions. We looked at the signs and symptoms. We looked at the classifications, different classifications of heart failures, okay? We have got 5 more minutes and I'm going to ask you a couple of questions over here. So the first question is, which one of the listed changes correctly describes the pathophysiologic mechanism involved in the production of pulmonary edema in patients with congestive heart failure? I give you 1 minute to answer this question. All right, there is one answer on the chat and which says C and which is the right answer. Increased hydrostatic pressure. Obviously, congestive heart failure means that there is congestion which is due to failure of the left ventricle, and the pressure will be transmitted to the lungs, and the hydrostatic pressure will increase in the capillaries. And thank you very much. It's Dr. Aziz from Ireland. And so the correct answer is C. And this is the last question the next one that I'm going to ask you. And we will continue tomorrow if we have time. Again, we will not do more than 50 minutes because it's difficult to have a lecture for more than 50 minutes. I mean, for you, not for me. So let me ask you the next question and then we will stop. All right, it is left ventricular dysfunction and the pressure is going back towards the left atrium and then to the lungs. Now, let me tell you, there is one answer over here and the answer is E. See, this is a very basic mistake. And that was exactly the reason I put this question over here. Which of the following chronic conditions, A and B are out, A is acute and E is acute. I'm asking you about chronic conditions. All right. And the correct answer over here, as I said, it is left ventricular failure. So the pressure is not going to the liver. It cannot be hepatomegaly. It's going to be pulmonary hypertension. Mitral valve stenosis does not occur in heart failure. It could be mitral valve incompetency, right? Because when the heart dilates, the valves, the leaves of the valves, they separate from each other. So you can say it could be an incompetent mitral valve. It could prolapse. I don't know, well, not necessarily prolapse, but at least it will be incompetent. So stenosis is not the right answer. So pulmonary hypertension is the right answer over here. A and E are out because they are acute conditions, not chronic conditions. And C is most commonly caused by rheumatic heart disease rather than left ventricular dysfunction. So the correct answer over here is pulmonary hypertension. And we have still not gone to the drugs. Hopefully we'll go to the drugs tomorrow. That was still setting the stage for going to the drugs. All right. So thank you very much. If there is any question so far, you can ask me. Otherwise, we can stop over here. Right. So I guess there is no question. And thank you very much for attending this lecture. Tomorrow, hopefully at the same time, we will start the lecture. All right. So I'll stop the recording now.